My name is Linda Appleby, and I would like to thank you for joining us this evening and welcome everyone to our final PH Awareness Month, Living Well Now and Beyond series. I'm the Executive Director here at Team Phenomenal Hope. This evening event is titled Living Well with PH Now and Navigating Misinformation. It's an enlightening topic, and we have a panel of medical experts to share their thoughts and answer your questions. This evening's event will be led by Dr. Jean Ellwick, and presenters are Dr. Wendy Chung, Dr. Lana Melendres, and Dr. Christopher King. So we really appreciate everybody joining us. And before we get started, I'd like to share just a little bit about Team Phenomenal Hope. We were founded in 2012 by Dr. Patricia George and Dr. Hunter Campion. They started out as a endurance team program where ultra endurance athletes competed in challenges to raise funds and awareness of pulmonary hypertension. This grew into the Let Me Be Your Lungs program, which pairs athletes and patients to build a global community of PH patients and athletes. And as we grew, we've added additional programs such as our Unmet Needs Patient Impact Fund, which provides grants to PH patients in need of financial assistance for non-medical needs. We've also grown our Let Me Be Your Lungs program, which provides a platform for those participating in Let Me Be Your Lung endurance challenges, such as our annual Pittsburgh 5K, half marathons, bike races. We just had a paddleboard race with an international racer. And so we continue to raise awareness and funds through our various programs. And we've also added a Global Impact Research Award that's awarded annually to provide better treatments and seek a cure for pulmonary hypertension. Team Phenomenal Hope cannot achieve all of these things by itself. We need your help in supporting those battling pulmonary hypertension. And today happens to be Giving Tuesday. And so if you'd like to support Team Phenomenal Hope on Giving Tuesday, you can go to teamph.org/donate and make a Giving Tuesday donation, which will be matched dollar for dollar by one of our very generous donors. So it's a great opportunity to show your support in our programs and our support of patients. I'd like to also thank our sponsors. We acknowledge our industry partners who support our patient-centric work throughout the year, without whom we could not do all that we do. So we'd like to thank Janssen, CVS Specialty, Bayer, Altavant, Acceleron, and United Therapeutics. I'd like to just cover a little quickly, a little bit of Zoom screen and housekeeping. I'd like to share some housekeeping items for this evening's session. Please make sure that your mic is muted when others are speaking and your camera off. There'll be an opportunity to ask questions later, and we'll do that via a Q&A box, similar to a chat box, but it'll be a Q&A box, and our speakers will field your questions. With that, it is my pleasure to introduce tonight's moderator, Dr. Jean Ellwick.
Thank you so much. It's my pleasure to be here and an honor. And I'm so happy to be able to reach out to the community at this time, important day for giving, and an important time to talk about all these things virtual. So what I would like, if I can, I would like each of us to tell the audience a little bit about ourselves. So my name is Jean Elwing, and I'm from Cincinnati. I've been here more than a decade doing pulmonary hypertension. And what I really, really like about pulmonary hypertension is how close we can get to our patients. And what I really want to be better about pulmonary hypertension is I want to reach more of our patients that don't have access to experts like you're going to hear tonight. So if you could tell the audience just a little bit about yourself, Chris, and what you would like to be able to make better would be great.
Sure. I'm Chris King. I'm the Associate Medical Director of the Advanced Lung Disease and Transplant Program at Inova Fairfax Hospital, and it's in Northern Virginia near DC. We have a decent-sized PH center. My interest is really, kind of the full spectrum of lung disease, especially the critical care aspects of it. And so I still work in the ICU, et cetera. I think we have a unique program where we kind of get not only, we would be the person's PH doctor or interstitial lung disease doctor, but and we would be their transplant physician. And so we get to have these really long-standing relationships with our patients. And that's a really enjoyable aspect of our program. I agree. I want to continue to kind of grow knowledge of pulmonary hypertension through research. There's a lot of exciting developments that are going on, and it's try and continue to push the boundaries of what we can do for patients with pulmonary hypertension.
No, thank you, Chris. And I think we all share that. We want to reach more people in better ways. So Wendy, what about you?
I'm Wendy Chung. I'm based at Columbia University in New York City, and I study genes. So I'm a geneticist and see both children and adults with pulmonary hypertension. And I've spent a large part of my time understanding the genes that are responsible for pulmonary hypertension. My dream is actually that we can prevent it, so that by being able to identify individuals at risk, potentially before they even develop at least symptoms, that we could maybe someday be able to prevent the condition and help people live longer lives by intervening early. So we'll see whether or not in my lifetime we achieve that goal, but that's what I'd like us to be able to do. Put us all the rest of the doctors, put us all out of business.
Yes, definitely. We'll take it. When we're ready to retire, we'll go out with a bang. I'm with you. And Lana?
Hey, Jean. Hi, everybody. First, I want to say thank you to Dr. George for creating all of this almost a decade ago, because I think that many of us share that same sentiment that we just want to reach more people, do more for our PH community. I'm Lana Melendres, and I'm in New Mexico at the University of New Mexico. I'm the medical director for the PH program. And I guess, I actually was drawn to this disease and educating patients because a patient is actually who I first met that really spoke to me in terms of just the need. And in New Mexico, a decade ago, we actually didn't have any providers who treated pulmonary hypertension. And so patients from New Mexico needed to leave the state to go to one of our surrounding states to try to receive any type of specialty care. And for me, I think there's such a gap in our outreach at times for patients everywhere, whether that be rural or urban communities. So for me, it's always been navigating how we can care for our patients across all spectrums of demographics as well as their disease process. So again, I'm just so happy to be here and with people who have such an extensive knowledge outside of what I would say my specialization is.
Well, thank you for joining us. And I think we all kind of share that same idea. We love this connectedness we have with our patients, and we just want to make sure everyone gets access to the same kind of care. So we're going to talk about some hard things now. We're going to talk about how we integrate virtual care with our very intense in-clinic care. Now I'm going to ask each one of you about, give me the scenarios who should really come to the clinic and those who we can really do good care virtually. So I'm going to start with Chris. So tell me, Chris, what your opinion is and what your experience is. Now we have more than a year of experience.
No, I mean,
or two.
With the COVID pandemic, we became much better versed with using telehealth, but there's a lot of challenges with it as well in terms of picking the right patients and knowing when it's time to come into the hospital. And there's certainly those patients that are very, very stable. Their symptomatology is good. and they've been stable for some time, that I think we're comfortable spacing out visits, and then doing some risk stratification remotely. We by pinning them down on sort of functional class, sometimes lab. You do lose things like the 6-minute walk test that we would typically get in clinic. Sometimes we can get outpatient echoes and things like that, but there are patients that we've been able to manage either with less frequent visits to the hospital, or some combination of sort of lab values and outpatient testing, along with telehealth. Some of our patients do live quite a distance from the hospital too, and for them, it's really burdensome to have to come for. We typically try to have our patients seen every 3 months or so, so about 4 visits a year if they're doing reasonably well. Sometimes more frequent for new prostanoid starts and things like that. So I'd say stable patients, patients that are coming from a distance. Those patients, I'm comfortable doing some telehealth. Patients that have worsening symptoms, feeling like they're going to pass out or passing out, heart palpitations, increasing short, and I think they need to be evaluated in person if, we get new consultations as well. And we can usually tell by testing at outside hospitals, whether it's somebody we can, do an initial telehealth visit or if they need to come in and see us in person. But that's sort of been our experience and our approach.
And I think that's pretty much what I've heard from other people. Do you think that this is something you're going to be able to keep doing?
I think so. It lends itself well to us seeing patients from distances, and so I do think there's some patient satisfaction. I think there's a convenience factor with it. It's also like sometimes a sick visit, it might be that you do the sick visit as a telehealth, and then you can kind of figure out, how worried you should be and whether they need to come in or not. And so there's, I think, other times where we can apply telehealth. So I do think it's something that's kind of become part of our repertoire. There's not many good things to say about the COVID pandemic, but the integration of more telehealth has been a good thing.
Mm-hmm. Yeah, we learned a lot about electronics, and we're not really good at electronics at baseline. So, Lana, what do you think? Who would be the person you would say, no, I got to see you face to face in this climate?
Yeah, I agree with so much of what Chris has said in terms of that patient population. One of the things that I've really tried to stick to as best I can is that for my new patients, those new referrals, I really feel like those are individuals that I would like to see in person. I think that although we use technology and social media seemingly all the time now, I think there is a component that we lose a sense of a connection with our patient and our patient with us. And in pulmonary hypertension, I have just found that you have to create this level of trust so that when we're asking patients to get all of these tests and labs or come into the hospital to be seen or start new therapies, that by developing that sense of family and community and trust, that we're a lot more successful with it. So in the situations that it's feasible to be able to have those patients come in, I think that for me tends to be my longest discussion outside of after our heart catheterization, just to be able to really see somebody in person, which a lot of things we can gather, virtually, but just watching somebody walk into my office or the way that they speak or bringing their family with them at times. On the flip side of that, I think that I've gained insight into many of my patients' life and situation and even community by having those virtual visits where just like you see me and you might see children come running in around me, that, people have homes and families and, responsibilities. And sometimes I think those often go unnoticed when you're sitting just in my clinic. So again, we gain these depths of understanding of our patients. For me, I agree with Chris completely. If a patient is coming from, for me, sometimes 4 hours away, that's just not a realistic thing to come in for that type of distance. And then throughout this pandemic, trying to find a place to stay or be able to, eat and provide for themselves and then have to drive that distance back. So frequently, those may be patients that, we can try and do a telehealth visit and maintain them without having to come physically be in our clinic or in our hospital.
No, I agree. It's a burden for a patient who has no health conditions to travel. And then we put a pump and a medicine that needs refrigeration and everything else on top of that. It gets very complicated.
One thing I didn't mention, we tend to partner with the referring pulmonologist for those patients that come from a distance, or referring cardiologist, and that way they can get some of the testing closer to home. And it seems like the referring physicians often like that, in that they feel like they still maintain a connection with the patient, but they have access to sort of input from us, and that's been a pretty successful way of managing things as well.
And just to speak to that, Chris, I think that has been something that, even aside from the telehealth, our communication with our colleagues, I think, has improved because we've been required to do so. And it is wonderful to meet those individuals in outside communities where you can work together to provide for the patient. And, often we used to be called sort of a black hole if you came into UNM because no one ever got any records out. They weren't sure what happened to their patients. And I think this is a situation where, now we have each other and they can be our eyes on the ground elsewhere.
No, that's really, really important. And I do agree. We have been better at communicating because we've had to, and maybe we've made some friends through it. So Wendy, I know you see a lot of patients distance. How are you dealing with the medical problems of licensing in different states, and how have you approached that? Have you gotten licenses in your neighboring states, or are you not doing telehealth for those patients? How have you done that?
So as you can imagine, it's a little bit different for us in genetics in the sense that it's not as much listening to the lungs or being able to do things like catheterization. So we've developed ways of being able to do things even around the world. It's also been nice because genetics is family care, really, when you think about it. And so I'll frequently have Zoom family reunions, really, where we'd be able to bring in multiple family members all at the same time, the same visit from all over the world in terms of this. And it's helpful for them to be able to talk to each other and really think about this as a family unit. So it's really been great to do that. We've even developed some technology to do the genetic testing where we don't need to draw blood. So we can do a cheek swab or we can do a saliva sample, and we can really have it sent in again from anywhere in the country, which allows us to do all of these things remotely. So in terms of the licensure issues, yes, I do have many more licenses now than when I started in terms of pre-COVID. I had a few before, but now many more. And truth be told, I guess I'm a sucker. Probably shouldn't say this as we're recording, but I also give out a lot of free care, to be honest, in terms of people who need it and not really worrying in terms of the licensure and being able to bill for these visits, really just help partner with some of the local doctors in terms of them providing local on the ground care in some cases with me whispering in their ear. And I think this is one of those cases where, as we talked about, the expertise, especially when it comes to some of the genetics and the very, very new things that we're learning, they haven't just sort of disseminated down to a lot of the folks in terms of day-to-day practice. And so this is, as we've been talking about, a way to get the very best care to the most number of people and to do it instantaneously from the day that we have a paper to the next day when we can be able to translate that into clinical care. We're trying to shorten that time to implementation down to basically zero, almost instantaneously.
Which is amazing. And this has really ramped it up, I'm sure. Do you think that you've gotten more resources to be able to deliver things in a way you want to through COVID in terms of virtually?
Well, that's a different story, but we won't talk about getting resources these days.
But. Well, at least Epic can do a virtual visit now.
That's true. We can do a virtual visit now through Epic, and we're all HIPAA compliant and private and secure.
Yes. Which could you imagine? And the patients listening right now, just think about 3 years ago. Could you imagine that you could do a virtual visit through your MyChart? I think that what we've done in such a short period of time just is amazing. So I don't know. I think I've learned a lot from all of you, like how your approach is very similar, and also then your different approaches, because of all of us are coming from different areas. And I actually have tried to figure out how best to adapt my virtual visits so they stay on time and I can deliver the care I want, and I can then do my regular visits. So I actually have slotted times for them, and patients then can jump into those virtual visits when they want to. I don't know if anybody else has done that. Chris or Lana, have you done anything like that, or do you just put it randomly in your schedule?
No, it's I have to book them sort of at the front or all in a row, because the virtual visits tend to go on time, whereas my clinic tends to run over. Inevitably their testing is late or the patient shows up late, and so if I book like a live visit and then a telehealth or a video visit, then I end up being late for the video visit. So I usually do it the opposite, or all telehealth for like one sort of clinic.
Yeah, that's what I've faced too. It's hard to put them, integrate them into a live clinic because of the timing. And patients are waiting for you, and you hear it ding on your phone that patients arrived. You're like, I'm still seeing the previous person. So I don't know, Lana, what do you think?
Yeah, I think that for me, most of mine end up being, they would like to come in and be seen in person, and it just changes to a virtual if something happens, right? A family member is sick, or they are unable to travel, or their ride wasn't able to show, and they actually call my clinic and say, can I switch this over to a virtual? Which I actually, we didn't per se talk about that aspect of it, but we're able to see people that normally would have just canceled. They would have said, I can't get there because I don't have gas money, or, my kiddo's staying home today, I need to stay there. And so I think that for those, I've tried to be as flexible as possible. And often if I can, I try to put them at the beginning of clinic, much like, Chris had mentioned. But I think, at this point in time, after the whole 2 years almost of COVID, I've just tried to be a little bit more flexible, where normally I'm a pretty rigid individual. So I think just having that flexibility, and often our patients understand that as well.
Mm-hmm. So great. I think that was a great discussion about when to see virtual patients. Now, the next thing I want to touch on is how do we work through trying to give patients the best scientific information we can amongst this situation we're in, where there's so much information out there, some of which is helpful to patients and some we would like to make sure they understand doesn't have good scientific basis. So how do you approach that, Wendy, with your patients? How do you debunk myths you face, and how do you address that?
Yeah. So again, I'll be a little bit different in dealing with the genetic aspects of things. What we've developed is we've tried to develop scalable methods of education, so that we've developed things that are and done it with the PHA community, or PHA in terms of patient advocates and patient-facing information. So we've got a series of videos that go in terms of the building blocks of understanding genetics and what the sort of genetic testing is available. One of those myths that we've debunked is, people thought it was incredibly expensive, thousands of dollars, my insurance company, I'll never cover it. And so I hope, started debunking that myth, because it is very accessible and it is covered by insurance, and started dealing with some of the things that we have commonly asked questions that people ask us all the time. And so coming up with FAQ sheets so that it saves time for everyone else. So for Chris and Lana, for instance, when they're busy in their clinic and busy seeing patients, when those types of questions come up, they can just refer them over here, and they don't have to take time away from their busy clinic talking about all the things related to the immediate medical care. So that's what we found is a way of getting consistency, getting the truth out there in terms of the newest scientific information. And every time we get a new paper, we try and actually put this out in terms of something for research communication in ways that with infographics and sort of easily to understand information that the average person can read and digest. So anyway, we'll keep doing that, and people hopefully can give us some feedback about whether or not it's working well for them.
No, thank you. And I think that's one of the ways I think we can make sure we're providing good information is by consistent education. And PHA is wonderful at that. The Team Phenomenal Hope is doing it. We are just trying as a whole community to reach people in all different ways. So thank you. What about you, Lana? How are you interacting with patients, and how are you working through some of these questions they have?
Yeah, I think, first, I just want to applaud Wendy for what you guys are doing, because, there's always ever-changing information that's coming out. And so by trying to provide those papers and opportunities to continue to improve people's understanding is amazing. And one of the things that we've tried to do is that when we have a new patient, I do the heart catheterizations. And so when I go in to talk to them about their new diagnosis, they get to meet a huge portion of my team, my nurse case managers and my advanced practice providers and my social worker. And I think that I've found we are able to connect on different levels of understanding for the patient. Sometimes what maybe as a physician we think is understandable and in common language may not be. And yet I find that patients have a hard time saying they don't understand. Nobody wants to feel that they don't understand, and then to actually, say that they didn't is even more difficult. And so what we do is we have created a welcome packet for our clinic, which goes through who each of us is, a little background about us, just to try to make us seem more accessible to them, and provide numbers for them to be able to call us or to email us. And then within that packet, resources for them. So if they're more savvy and are able to use, technology and computers to, reach out for like the PHA, we provide some of those websites because we want them to get good information if it is going to be outside of our discussion. And then the next piece is that we create very frequent follow-ups to their new diagnosis that are specific to education for the patient, whether that be about the medications or about diet, about exercise. And so trying each visit to implement a new information to them for them to be able to continue to advocate for themselves. I found that my patients who feel that they can be their own advocates or their family members and caregivers, that they come up with tremendous questions. And for me, I say, there's, just like they always said in school, right? There's no dumb question. And for me, that's the case. But often I think that our patients feel that they're burdening us because it takes more time, that we have a dinging on our phone saying we're supposed to be somewhere else. And so I just try to remind them that this is their time and that they are able to ask anything and everything. And that if I don't have that answer, I will either find it or find somebody who does. And so it goes back for me, that trust amongst my patients and my program and my staff, so that they feel that they can have those conversations with us. Because let's be honest, sometimes we don't always agree, but we need to be able to have a conversation as to why.
Right. And sometimes there is no right answer to many things, but you at least need to work through the logic so people can make the best decisions for themselves. So I agree with you, Anna, very much. And I think trust and education, two really important pillars of making sure we can share the information we think is best. And Chris, how are you approaching this?
I think similar to what's been said already, we do tend to rely heavily on PHA sort of educational materials. We have, some homegrown educational materials as well that are kind of more tailored to our site. We have RN coordinators that are a good resource for our patients as well, and they talk with them quite frequently and check up on the patients, especially if they're starting new medications, things like that. we have a local support group, and they provide a lot of education as well. And so we try to make sure people realize that's an opportunity for them to sort of meet other people that with the diagnosis. And I think that can help with that sort of getting the patient perspective on some of these things. So I think our view as providers of what it's like, or when you tell somebody, oh, you may have symptoms when you start this medication, but it's going to get better. Hearing that from a patient that's actually lived through it, I think carries a little more weight sometimes than hearing it from a provider. And so, sometimes we'll even pair a patient with somebody that's a more experienced PH patient, so they can gain that sort of patient perspective and get some of those answers that they might be looking for.
The real world experience.
Right.
Which I think, we live it, right? We want to be able to pair with somebody who can show us the ropes. So I think that's really great. And if you also have a group of patients that are willing to share their time, that's also very, very valuable. And we did have one person ask a question about their concern that we're doing a good job talking to people and working with the providers near homes and things like that. But how are we making sure the patient gets communicated to? Because, if we're seeing patients less and we're doing our virtual visits and we're doing all this stuff for education, but how are we making sure they really grasp what we're saying? Do we have any way to check back in and say, hey, do you have any other questions? Or is there a check-in with your staff that calls the patients? Or do you have a pharmacist that checks in? What is your approach to making sure everybody is in the loop, including the patient or the patient's caregivers that really want to know what's happening? So Lana, what is your approach?
Again, when we're
Chris,
starting
please.
medications, our RN coordinators tend to reach out quite a bit. The liaisons from specialty pharmacies for a lot of the medications also are in frequent contact with our providers, and will provide feedback on whether they and certainly if they feel like there's educational gaps or there's something that the patient's not understanding. And so that's a good way for us to find out about how patients are doing, say on a new medication. And we do try to book frequent visits, particularly for sicker patients or maybe newly diagnosed patients. So they might be seen more frequently earlier on. So, we can try and, gauge how they're doing and whether they have new questions. They all have emails and phone numbers for the clinic, et cetera, and trying to do fairly extensive counseling on what to expect and common side effects, things like that, so that they're prepared when they're starting and feel like they know not just what to expect, but who to contact if things aren't going well.
So clear direction, clear expectations, and ways to ask questions. So that's your approach. Right. What about you, Lana?
Yeah, I think all of that is essential. And for me, I utilize a lot of sort of a multidisciplinary approach amongst, my palliative care team, because they often are able to gather information just in terms of the quality of life that, my patient is looking to get to. And sometimes we overlook that when we're starting medications. And so the goal for me is that if there are those frequent touch points with my social worker, with my, advanced practice providers, with my palliative care teams, or maybe a rheumatologist, that I really find that we're able to get hopefully to the heart of the matter and really make sure that those lines of communication are open. But I think the question was really to the point, was that this is truly about our patients, and that if we are not finding, filling that gap between what we're as physicians are interested in doing and what our patients' needs are, then we still have work to do, which, I think tonight is part of growing from this.
Mm-hmm. Yeah. And I think that's what we want to make sure, that all of the efforts we're putting forth lead to the patients understanding what we want to help them achieve, and do it in a way that is most easy to digest. Because sometimes I feel like our first visits are just totally overwhelming. And I feel like, oh my gosh, maybe I should have done less. and separated it out. And I think that we have to keep asking ourselves, like, how can we do this better? How can we reach people better? And how can we make sure that the retention of what we talked about is as high as we can? So Wendy, I know you have some unique ways, as you have mentioned, through education to try to achieve those things. What other things have you tried?
So like others, we don't do it alone. We have a multidisciplinary team that includes a specialist called a genetic counselor, and they're specially trained both in terms of education as well as psychosocial support and family dynamics, and trying to think about all of those different factors. And so as a team, I think we do a pretty good job of that. We always actually have, just like we have an electronic medical record with our consultation notes, we actually take the genetic information and translate that into a patient-facing report. So every time we get the gobbledygook of the DNA alphabet letters coming back, we translate that into something that's written in a lay, sort of patient-friendly manner to be able to take some of the complexity and distill it down to the bare essence of what it's needed. And a lot of what we do is, again, because this is a family affair, we don't want to put too much burden on the patient to have to share this information, because it's hard to explain these complexities. And so we actually write letters for them to share. It was just Thanksgiving, so it's one of the times we encourage our families around the holidays, Thanksgiving, the December holidays, and New Year. It's when they're seeing families to share this. And it's written from the point of view as a family member. There's pulmonary hypertension in your family. If there's a genetic factor, we identify what that is, and then connect them with resources so that if they want to be able to get testing, they can. And that takes off some of the burden with complexity of emotions, sometimes guilt, sometimes confusion that comes with this, and just makes it real simple. And I've had, as a famous sort of example, one family where they shared it actually with over 100 of their family members. They got an email distribution list, and that was their holiday card, was to send it out to all their family members. And it was a really good way, actually, for us to be able to help the family as our unit of care.
Wow. Yes. So everybody's doing things a little differently, but also, the same message, trying to make sure we reach people in a way that is usable for them. So, and what we want from our patients is to have feedback. If we're not doing this the way that works best for you, you got to tell us. And we are adaptable. Obviously, we've been able to adapt with COVID. We can adapt to what you need and to make sure it's the best experiences we can give you. So we're going to change gears, and this is a little bit more fun. We're going to talk about how the heck we're going to get home for the holidays in a safe way, and what are some recommendations, masking, vaccinating, all of these things. So lots of opinions here, and most of this is our opinion. So just take everything with a grain of salt. So I'm going to start with Lana, and I'm going to ask you to give me your 10 lines that you're telling patients, or 5 lines you're telling patients about home for the holidays.
Yeah, I think, every community is different. Here in New Mexico, we tend to be a very family-oriented, tight-knit community, but those families tend to be, substantial numbers that would normally get together. And so, we have really tried to advise that, because there's generations within these families that would be gathering, to be thoughtful about who's able to be vaccinated, what health, where their health is now, what types of things they're required to do outside of the home. Because I think really when we all look deep down, we want to protect each other. We really do. And families especially. So for me, it's been difficult because at times we're not able to be with the ones we love most, but that is so that we can be with them, over the course of many, many years to come. So I talk to them just like I do about pH. It's risk and benefit. We sort of have a risk assessment that we look at for our patients in terms of their disease. And I try to pull it back to that, is that, we do all of these things that sometimes don't necessarily in the moment feel as good, or the medications we start have side effects, but we do it for their greater long-term good, for their health and their longevity. And so, looking at it in that same way, the risk that they themselves as well as their family might have if someone were to contract COVID, versus the benefit of those moments. And I think for each of them, they have to make those decisions on their own. I'm not here to tell anybody how they're supposed to live or what they're supposed to do, but I can advise and I can bring good information in terms of what's going on with COVID at this moment, what's going on in terms of the vaccines, how you might be able to gather in a more safe manner. And so that again is like all things we talk about with our patients. It's a discussion. And, I think that there's no right answer for any one person, but each person will find a different way to navigate that.
So a very, very good point that it really is a risk benefit assessment for these visits with your family. And I think that we miss really important things if we don't see your grandkids and you don't see your children. So I think that that's a very important point, Lana, that we have to be open to people taking a little risk to see their family because it is such an important part of our lives. So how are you approaching this?
I was just going to say the only other thing I wanted to add to that, Jean, was that what I've seen in so many of my patients has been, heightened amounts of anxiety and depression, and just mental health has been truly affected. And already dealing with, a disease such as PAH, I think that is compounded by isolation. So at times, I think that just having somebody there to support them physically is truly important. And so times that I might tell somebody else, like, hey, stay away from each other. In this situation, sometimes my patients' overall health and how they do long-term is greatly diminished because they're not seeing the people that are meaningful to them.
Very true. And I have more people with anxiety more than ever. I don't know. How are you even addressing that, Lana? Is it something that you're just integrating into your visits now to discuss how people are feeling with anxiety and depression? I mean, we were always talking about it, but I feel like I'm talking about it more.
Definitely. And I will love to hear what both Chris and Wendy have to say. I mean, just today, my patient in the cath lab said, I was never like this. I was never anxious. I can't seem to get a hold of it. And apologized continually while I was doing the procedure, saying she's so sorry that she's so anxious. And I said, you have an absolute right to be anxious. There are so many things. So for me, it's validating those feelings of insecurities and anxiety and, feeling blue or depressed. And I'm very fortunate to have a social worker as part of our clinic who is able to provide resources, counseling in some ways, and getting them to others to be able to address that, because that can affect, their quality of life. But I don't know, Chris, Wendy, I mean, maybe I can learn from you guys if you have other strategies on how to do that.
I think the first thing is sort of recognizing that it's a problem and sort of inquiring about it. I think a lot of times
we had a little bit of dropout there. Chris, I don't know if you would mind telling us how you're approaching it.
Sure. What I was saying is I think it's really important to, recognize that, it's certainly heightened with COVID, but with pulmonary hypertension or any sort of chronic medical condition, that anxiety and depression is often comes along with the diagnosis, and taking this more holistic view of the patient. We tend to think of these things as either a lung disease or heart disease, but they really affect your whole body. They affect your muscles. They affect your mind. And so really inquiring about it and trying to get all those things addressed. One thing I'm
not sure if you all can hear me.
I can hear you.
I think, Jean, you're just kind of going in and out on us sometimes.
One thing I would say about COVID and visiting family, I feel like we'd be remiss if we didn't mention that vaccination is really important. I think that, I've been taking care of.
So, Chris, how are you approaching the anxiety that people are facing?
I feel like, trying to acknowledge it is really important, and trying to, I'll actually prescribe medications if patients are interested. And, I feel like a lot of times for pulmonary hypertension patients, as their physician, you almost become like their primary care doctor. And so we end up, taking on that role. We do have social workers.
I am not sure what is happening, but I am not able to hear you all. So, okay, you can hear me. I just can't hear you at the moment, which is very unfortunate. So I would like, if I can, I would just like you guys to just tell me one or two things that you've been able to tell people about vaccination. Have you encouraged them to get boosters right before they go out and they join their family? Have you been like that, give them 2 weeks before they have their holiday events? Are you encouraging people just to be with people who are vaccinated, or you're taking the risk benefit kind of approach? Because everybody has some people in their family that are not vaccinated, and everybody's been asking me those questions. So Wendy, what has been your approach there?
So I have to say that I don't know if I'm typical. So number one is I believe in vaccines very, very generously. And so in a good way with boosters and being able to do very broadly boosters for folks who have been vaccinated at least 6 months ago. We've been encouraging that as the little ones and younger folks can get vaccinated. We're certainly encouraging that as well. And I guess the thing that I've done, because many of my patients are nervous about this, is I won't say it's always right, but there is now over-the-counter testing that you can do that's essentially point of care. And so we've had some of our folks that will have reassurance if they do have people, especially that are unvaccinated or have been traveling and may have more exposures recently, just to the number of people they've been in contact with, do some point of care, basically vaccination, and then be able to feel more comfortable being at those family events and with others who may have been traveling.
Thanks, Wendy. And I'm going to go ahead and just jump in because I know that Jean's having a little trouble with some of the connection. But I appreciate that. And I think we're very similar in terms of just really needing to talk about the importance of vaccination. And I guess I just want to ask, in terms of that, Chris, are you getting questions as to the safety of the vaccines, and how do you address that? Or if they say, which one am I supposed to get? How do I know? When do I go back? Do I get the booster? Do you have a specific dialogue that you have?
I do. I mean, I was involved sort of with the care of critical care COVID patients sort of from the beginning. And so, feel comfortable sort of speaking to patients about it, because we were there before the vaccine and saw, lots of patients really, really sick on ECMO, patients dying from COVID. And I have to say, since the vaccinations have come around, the numbers are significantly better. And for the most part, the only patients we're admitting to the ICU now are the unvaccinated patients. Every once in a while, the immunosuppressed patient. We've had very few vaccinated patients that are sick enough to be hospitalized, and really almost none that weren't immunocompromised that are sick enough to be in the ICU. And so my personal experience, and I know that, and the overwhelming, the evidence shows that vaccination is effective. And I've really not seen anyone with significant side effects from the vaccine. I think that they're rare, and that the risk of having the vaccine is far outweighed by the benefits of the vaccine. We typically recommend the mRNA vaccines, and so for people that aren't familiar with that term, that's generally the Moderna or the Pfizer vaccine. We're not brand loyal to either one of them, but feel that the data is a little stronger for the mRNA vaccines than the Johnson & Johnson vaccine. Although any vaccine is better than no vaccine at all. I know there's some people that are a little scared of needles, and they're like, one shot is all I'm willing to do. And we do recommend boosters, and we're recommending that people, talk to their family about being vaccinated. In fact, we recently made it, a requirement for our lung transplant patients to to get vaccinated before they could be listed for transplants. And we strongly encourage their family members to, and their sort of inner circle to be vaccinated. And so, having these patients, let their family know that they're at risk of severe disease and, don't have the same reserve and really, so if their family members want to protect them, them getting vaccinated is an effective means of doing so.
No, thank you, Chris. And sorry about my interruption. My internet just disappeared. So, Lana, just give me a little bit of recap. Was a similar kind of approach from your side too?
Yeah, I think we all sort of are trying our best to approach it with that education piece and really the importance of the vaccines. So I think I can't believe kind of coming up toward an hour. So I think we were really able to move into that discussion on maybe the kiddos and pH and some of the situations that they're in right now. So I'll hand it right back over to you, Jean.
Oh, no, thank you. And thank you for helping me making this go smoothly. Wendy, this is your bag. So tell us how to make sure we take care of our kids with pulmonary hypertension during this difficult time.
Yeah, so kids are complicated. Kids are a lot more different, in my opinion, than the adults with pulmonary hypertension in the sense that many of them have other comorbidities. So they may have either they were premature when they were born, or they've got diaphragmatic hernias or congenital heart disease or other things going on. And so their care can be more complicated. And they often have, as a result of that, we were talking about some of the anxiety and other issues. Some of them have just been through the ringer, to be quite honest. And, having that white coat fear is a real thing for them. And it's been really trying for them. That on top of their parents have just been scared to death during COVID, really, really obviously afraid for them and their lives. And unfortunately, I think understandably, but been overprotective in some cases in terms of keeping them home from school. And that whole socialization and learning, I think, has really, really had a bigger impact, even for them than some of the adults, just because they're in their formative years and really sort of shaping themselves and learning. And it's been a very different experience. So I think we're all trying to get them back to normal as quickly as we can, trying to do it safely, obviously, as we're doing it. And always has to be customized to what their individual circumstances are, what their needs are from an educational, social, emotional point of view, and their medical needs. But I'll just say I feel it's more complicated for them than it is for many of our adult patients. I don't want to dismiss the issues facing adults, but it's more complicated for them. And then I'll just throw in the genetics because I love every opportunity I can to do that. The kids are very, very oftentimes genetic in terms of their pulmonary hypertension, more so than we see in the adults, especially the elderly. And so just for any parents that might be listening to this, I really implore you, do talk to either a genetic counselor or a geneticist or your pulmonary hypertension doc about just what's up with that genetic thing. Because with this, if you're worried about either having another child in the future who might have PH, or if you're worried about other things that might be associated with it, it is a more complicated story in the kids, but the genetics are getting much, much better in terms of understanding this for the children. And a lot of things we can do in terms of supporting them, not just for their lungs and their breathing, but for the other things that can go with this.
Thank you. And I think that there's so many layers. Just being a kid is hard. Then having an illness is hard. And then having a genetic illness is even harder because of all the things that go along with it in your family. So thank you for those important points. And thank you, everyone. This was so great. I think it was so good to talk about right now because we are talking about another little problem with COVID, and I'm not sure what it's going to lead to, but we're faced with this over and over again. And it's almost like you get a breath and then you get pushed down again by the stress of everything with this infection and how we're managing it. But at least, as we've all said, we've at least learned some skills, how to take care of patients. And we've learned how to make sure we're communicating and helping patients understand. And I really appreciate all of your insights. And I so appreciate everything you're doing to make sure that we reach as many patients as we can. And really, I think we're up on time. Of the questions I saw, really the biggest things were about making sure we educate, communicate, and I think we touched on all those important points. Any closing remarks that anyone has? Wendy's, anything to part with on end of November pH awareness and beginning of the holidays?
No, I hope it's a time to be joyful. I know it's been a rough couple of years, but I just think from, thinking back to Thanksgiving, there is a lot that we all have to be thankful for. And I think when I think back to the sort of the treatments that we had 10 years ago for pulmonary hypertension, it's just a brand new day. It's a brand new world. And so just in my lifetime, in terms of seeing treatments, I have a lot of hope for the future. And I am thankful for that. And all of the great people that we've got in the community, all of you guys and all of the folks out there listening to us.
I think for me, it's just that it's a reminder of how we pull together in difficult times, and that the human spirit finds a way to make it through. And, with that, each wave of this going on, we've found new ways to adjust and adapt, as you've mentioned, Jean. And I'm just so appreciative to be here and to continue to try and connect with everybody out in our PH community, and to thank, Dr. George and in her entire group in having us together.
No, I mean, I think everyone said it pretty well. I think, it's a great organization. I appreciate you guys having me on to make some comments. It's nice to see the, PH community kind of come together and to take a more patient-focused look at things, I think is really a great thing. And I hope it's something we can continue to encourage and expand on.
No, thank you. And thank you. It's my pleasure to be with you wonderful people. Honestly, it makes me feel warm inside. And I'm going to hand it over to Linda, and she's going to wrap it up for us.
Wow, what an incredibly informative session. I just really thank Doctors Ellwig, Melendres, Chung, and King for your time and sharing your insights and terrific information about how patients can navigate misinformation and how they can connect with their care team, either in person or virtually. This has been a marvelous end to Pulmonary Hypertension Awareness Month. And I want to make everybody aware that our Patient Unmet Needs Fund opens at noon tomorrow, and we will be accepting applications. I know a lot of patients this time of the year have a lot of needs, so we look forward to getting those applications and processing them as quickly as possible. And I would like to remind people too that we have our next patient support group coming up in January. We haven't set the date yet, but watch our social media and our website for that information and our newsletter. And finally, just wanted to again thank everybody. This has been great, and stay tuned for more patient-centric opportunities from Team Phenomenal Hope. So thank you everyone for joining us. And again, we'd like to thank our sponsors, and you see them up on your screen. And during the program here, we had a couple of donations come in for Giving Tuesday. So again, we'd like to remind people that there's still time to make those donations at teamph.org/donate. So thank you very much for your time. Have a great evening, everyone.